Good morning, good afternoon, and good evening to everybody joining us from around the world. Welcome to this webinar on the possibility and promise of outcomes-based financing for global health. For those of you who don't know me, I'm Emily Gustafson-Wright. I am an economist and senior fellow in the Global Economy and Development program at the Brookings Institution based in Washington, D.C. I lead our work at Brookings on innovative and outcomes-based financing and have been researching impact bonds and outcomes funds for over a decade now. Prior to that, I spent a decade doing research on the impacts of innovative health financing initiatives, including low-cost community-based health insurance schemes, primarily on the African continent. Today's webinar features a wide range of experts who have been involved in outcomes-based financing or similar mechanisms for health on different continents. The webinar is a follow-up to a one-day workshop that we held in Zurich in March, in which we brought together some of the world's experts on outcomes-based financing and global health to discuss their lessons learned and ambitions for the future. I'd like to thank the Farm Access Foundation, Joop Lange Institute, and Achmea Foundation for their close partnership on this event and the previous work. These organizations and the LEGO Foundation provide generous support to the Center for Universal Education at Brookings, which helps to make the work we do possible. I'd like to reiterate Brookings' commitment to independence and underscore that the views expressed today are solely those of the speakers. So our goal today is to illuminate the experiences to date and to collectively engage in the challenging question of if, how, and where outcomes-based financing may help to address the myriad health challenges faced globally today, including the rise in premature deaths from non-communicable diseases, the failure to reach targets on such diseases and malaria and TB, the compounding global crises weighing on the most marginalized populations, including climate change, geopolitical instability, and displacement. So after I provide some background on outcomes-based financing and share some data from the global landscape of outcomes-based financing, we'll hear from Nicole Speaker, who is the CEO of Farm Access Foundation, who will also share a summary of the insights from our workshop in Zurich. And note that we recently published a blog post summarizing that event, which can be found on the Brookings website. After Nicole, we'll hear from our esteemed panelists, and that will be followed by an opportunity to ask questions to the panelists. If you have questions, please submit them by emailing events@brookings.edu, or you can also use X or Twitter by using the hashtag OBF, the number 4, and global health. So that's hashtag OBF, number 4, global health. All right, so with that, we'll dive into a bit of a background on outcomes-based financing, just to make sure that we are all on the same page. All right. So I'd like to place outcomes-based financing in the broader landscape of innovative financing mechanisms. So in innovative financing, we have both innovative sources of funding as well as innovative ways of delivering that funding. So on the left-hand side of this table, you can see such things as sin taxes, airline taxes, carbon auctions. Those are examples of innovative sources. And then on the right-hand side, we have innovative delivery mechanisms, which includes non-contingent disbursements and contingent disbursements. And non-contingent disbursements includes things such as bonds and notes, guarantees for risk mitigation, unconditional cash transfers. On the right-hand side, we have the broader category of results-based financing. And just to note, in each of these categories, you can also have public-private partnerships and blended finance that include elements of these different types of mechanisms. So we're focusing on results-based financing. And what is results-based financing? So in results-based financing, funding depends upon the achievement of pre-agreed and verified results. There are lots of different types of results-based financing, and the way that they differ is primarily by who it is that holds the financial risk or the contingency for the payment. So in the left-hand column, you can see that this includes, this can be national government, local government, service providers, investors, or beneficiaries. In the middle column is the broader instrument category, and in the far right, the RBF instrument. What we'll be focusing on today is outcomes-based financing, which includes social impact bonds, which also is called pay-for-success contracts, outcomes contracts, development impact bonds, environmental impact bonds, outcomes funds. And for this category of results-based financing, the entity that holds the financial risk, immediate financial risk, direct financial risk, contingency for payment is the investors. So how does this work? Investors provide risk capital to service providers to deliver services to a population in need. And then an independent evaluator verifies whether the service provider has achieved some pre-agreed impact metrics. And then the outcome funder, in the case of a social impact bond, is government. In the case of a development impact bond, and primarily focused in low and middle income countries, could be a third party such as a donor or a foundation, for example. Note that there are also social impact bonds to date in middle income countries. Development impact bonds are not the only type of impact bond that can exist in a lower middle income country. So the investor provides the risk capital. There's a verification whether or not some agreed upon outcomes have been achieved. And then if outcomes have been achieved, the outcome funder pays the investor back their principal plus some return or partial return, depending upon whether or not outcomes have been achieved, or no return or no principal back if outcomes have not been achieved. Globally today, based on our Brookings database of verified projects, so all the projects in our database are verified by the projects themselves. So that includes nearly 260 projects, of which 240 are social impact bonds, and 18 are development impact bonds across 40 countries. The majority of those are in the United States and the UK, well, the UK first, and the United States, Portugal, and the Netherlands. So which sectors are these projects, do these projects exist in? Overall, if you look at the whole landscape across the entire globe, the majority are in the social welfare sector, followed by the employment sector. Health and education have the same amount, and then followed by criminal justice, and then finally environment and agriculture. But in low and middle income countries, this looks a little bit different. There are 11 in the education sector, followed by 10 in health, 8 in employment, and 1 in the environment sector. So today we're talking about health, and as you can see, there aren't as many as one might think in the health sector. How are these distributed? The majority of them are in the UK and Japan, which have the most in the health sector, as you can see from this graph. That's why those dominate those regions. And here is a breakdown by health impact bonds by health area. So you can see that the majority are for non-communicable diseases, and much of those are in high-income countries, followed by behavioral health. And then we have geriatric or end-of-life care, sexual and reproductive health, maternal and newborn health, disability, and communicable diseases. So I think this is very interesting for our conversation to think about, where the opportunities are, where we've seen the projects so far. So with that, I'm going to turn over to Nicole. Nicole, as I said, is the CEO of the Farm Access Foundation, which is an international not-for-profit organization dedicated to strengthening health systems in sub-Saharan Africa, with over 20 years of experience on the ground in Africa. Dr. Speaker is has focused on developing and scaling innovative models for quality healthcare. She's also the founder of Safe Care, which is an initiative to improve clinical quality using transformative digital solutions in resource-limited settings. So with that, I'll turn it over to you, Nicole.
Great. Thanks so much, Emily. And I hope you can all hear me okay. Really excited to be joining this webinar today. As Emily said, my name is Nicole Speaker. I work for Farm Access. Farm Access is a transformative organization that really aims to reduce out-of-pocket expenditure and come up with innovative financing solutions to improve better healthcare on the African continent. So why are we so extremely interested in blended financing models? 15% of the global population is on the African continent at the moment, and that number is rising. I think at the moment, India is the most densely populated continent, but Africa is expected to take over that pole position in the next few years. 21% of the global burden of diseases. So if you're born on the African continent, you simply fall ill more often than if you're born, for example, in the Netherlands, like I was. And then 2% of the global expenditure of healthcare. So health systems in low and middle income countries, specifically those on the African continent, is not poor because people don't know how to do healthcare. It's poor because there's not enough money into the system. And this is actually a moving target. Despite all the progress made towards universal healthcare coverage and the advocacy and the global movement to put more money onto the African continent, including local resources, what we've seen is that the economic crisis that hit almost all of us in the past couple of years, combined with the impact of climate change, where we're actually seeing diseases rising, means that if we don't do something different, we're just chasing a moving target, and we need to be smarter about this. And the interesting part, as Emily also alluded to, is if you do impact bond financing, you're able to create a blended financing models where investors are actually willing and able to take the risk, as we've heard during the event in Zurich a few weeks ago, where we put 30 experts in the same room and we started addressing various initiatives that have been done in healthcare throughout the world. But we've also, and I'm sure we'll be hearing that from our panelists today, we see that investors are actually willing and able to put up that risk money with a new innovative way, so that global institutes and governments have to pay for the outcomes, but they don't have to pay for the risk of setting up these healthcare systems. So it's actually a great way to move into a much more smarter use of healthcare financing, bringing public and private partnerships together. And during the Zurich event, there was various models discussed, which are also described in the blog that Emily and Brookings Institute published. But just to give you an example of the work that we've been engaged in together with a partner organization, Joep Lange Institute in Cameroon, which was supported by Achmea Foundation, is an outcome-based financing mechanism where we introduced hepatitis C treatment, which for those of you who are familiar with it, is actually now a curable disease. You can give people a medication, measure 3 months later with a simple test, and you're actually able to cure 96% of the people that were before with a disease that comes with a lot of morbidity and often ends with mortality. And you're really able to give people their lives back. But we also discussed other bonds, just noticing the one in Utrecht, I hope I pronounced it the right way, in India, where the improvement of quality of care actually saved 13,000 lives. So it's interesting to see that these models are working, that investors are willing to pick up the risk, that you're able to spark efficiency, value, and impact, and that in fact you're sometimes able to save lives permanently from a chronic disease. But one of the things that we noticed during the learnings of the workshops is that the buy-in of the government is crucial. Evidence is needed beyond just the savings implemented. Next slide, please. Can I have the next slide, please?
Sorry, just 1 second. It's frozen for some reason.
So I'll just keep talking while we get to the next slide. And apologies for some of the technical glitches. What we see very often in these proof of principle projects is that it is one investor willing to invest in an outcome-based financing mechanism. But it takes a lot of time to set it up. And in fact, some of the partners, I won't mention any names, said that the people that benefited mostly were probably the legal people because of all the contracting and everything that had to be done in the back. And that set up a lot of time and difficulties. The M&E framework in low and middle income countries, it's very difficult to collect data, especially when it comes to health outcomes. We've shown you the example of hepatitis C, which was a simple test at the end of the treatment. But we've worked, for example, also with outcome payments for maternity care, where you can imagine that the complexities during a maternity journey are much more complicated. And to measure progress towards better outcome is a more complicated situation where actually the cost of setting up an M&E framework and then collecting the data is difficult. And then attracting the outcome payments. One of the things we learned when we set up the hepatitis C bonds is despite the overwhelming evidence that this was working and we could actually bring people their lives back, was that the cost of this treatment was about $1,500 a patient to treat them. Now you would argue that there is a very low cost that should be worth it, but in a healthcare system where universal healthcare coverage is very limited, and often the available financing to treat a family per year for general healthcare is somewhere between $50 US. You can imagine that this is relatively expensive, and that because it's very often unclear what is actually the cost of not treating these patients, the economic burden, the morbidity before mortality sets in is not known. It is difficult for governments to then take up a balanced decision to take up these new payment models. So we've seen a lot of proof of principles, but we haven't seen the high uptake yet. Next slide, please. Now, why should we worry about this? I actually stole this slide from Stefan Larsson. I'm at a conference in Amsterdam at the moment, and he's walking around, and I think it's a very good slide because it shows where we're heading in the world with universal healthcare coverage. We have a value crisis. There's not enough money in the system to treat everyone. And as I mentioned earlier, we have a moving target. But we also have an evidence crisis. Actually, a lot of the treatment that is given to patients are not supported with data. We're not really sure if they align to medical protocols that should be given to these patients. And especially where we see more and more the complex environment where people have multiple morbidities, is that we get really confused on how to treat the patients. And in fact, one of the biggest discussions also here at the conference today is the purpose crisis, where more and more doctors are getting frustrated and nurses are getting frustrated with the work. The COVID pandemic caused a lot of mental issues and people are leaving the professions. So we need to be smarter and we need to do this well. Next slide, please. Now, should we all be depressed about it? No, because the results of these case studies that we discussed in Zurich and that I encourage you to read up upon, but also I'm sure the panelists will talk a lot about it, is that these models actually work. They bring in blended financing, they bring in new ways of partnerships, and they're promoting better health outcomes. But we have seen that the development of these PPPs are difficult. The learnings are that you need to bring in government involvement from the start, but even that a guarantee, and I already gave you the example of the government of Cameroon that simply has to struggle with choices of where they put their money into healthcare prevention and healthcare treatment. So we have to advocate evidence building through use cases, not only showing what happens when you do the right things, but also what the cost of care is when we're not doing anything. And because that is so often hidden, we don't know what the burden of disease is, because a lot of patients are actually not showing up on the hospitals. It's difficult to measure that. We're not really showing the evidence that we're actually better off economically and from a health perspective of bringing in patients for early treatment and other disease management. Now, there is a huge opportunity ahead of us. As I mentioned earlier in my talk, the cost of actually collecting the data has been immense and often by far outweighs the cost of implementing these treatment programs, and they've also prevented a lot of these programs to scale. But the reality is that the world is changing. We're rapidly seeing the progression of the adoption of mobile technology and mobile phones throughout especially low and middle income countries, where more than 90 to 95% of the people are now collected through a mobile phone, which means that the cost of connecting to them, asking, for example, about patient-reported health outcomes measurements, has become much more lower as much more real time. But interesting enough, you can now create models where patient journeys actually start with the individual rather than just starting with the healthcare provider. And this allows you to monitor patient journeys in a much more natural collection of information, because patients are already going to the healthcare facilities. The facilities are already paid through claims management, are already collecting information through HMIS system. And with the promotion of open data standards, we should be able to tap into this information and reuse that information for new financing mechanisms in much more transformative ways than we have to be able to do up to now, where we needed to add complicated data capturing systems that were often also perceived by doctors and nurses as adding to their workload rather than reducing the workload. So we really need to think, moving forward with these new financing mechanisms, how do we tap off the digitalization of the healthcare data? And then maybe my last point before I like to hand it over to Emily and the panel, because I very look forward to the discussion, is how do we bring in the big institutes? Because showing by doing, we need to start bringing these models to scale and also demonstrate how we can start reducing efficiencies and effectiveness in setting up also the administrative backbones behind these innovative financing models. And as governments are a bit hesitant to bring in that next step, could we actually also start by some of our amazing big initiatives that have already saved so many lives in HIV treatment, in malaria treatment, and see if we can bring some of the learnings of these innovative financing models and see how we can capture that into these big initiatives, hopefully also then leveraging the money that the governments themselves put on the table to treat people better. So with this thoughts, I hand it back to Emily, and I really look forward to a stimulating panel discussion. Thank you very much.
Thank you so much for Nicole for that excellent summary and for highlighting some of the opportunities as well as some of the challenges. I would now like to introduce the panel, and if you all can turn on your cameras, I'll introduce you. Thank you all for joining. So this panel will be moderated by John Fairhurst, who is the head of private sector engagement at the Global Fund to fight AIDS, tuberculosis, and malaria, where he drives catalytic impact initiatives through engaging private sector resources, philanthropy, and innovative finance. Prior to his work at the Global Fund, John was director at UBS Optimus, where he led the team developing new products and innovative financing instruments. We're also joined by Dr. Farid Abdullah, who is the director of the Office of AIDS and TB Research at the South African Medical Research Council. He is a medical doctor and a specialist in public health medicine. He also holds a part-time appointment as an HIV clinician in the Division of Infectious Disease at the Steve Biko Academic Hospital in Pretoria. And he also serves as an honorary professor of public medicine at the University of Pretoria. In 2022, Dr. Abdullah was appointed as Knight of the French National Order of Merit by President Macron. I guess that means we should be calling you Sir Doctor or Dr. Sir. We're also joined by Dia Martin, who is Managing Director on the Social Enterprise Finance team at the U.S. International Development Finance Corporation, where she originates debt financings across multiple emerging markets. She also leads the Portfolio for Impact and Innovation program, which focuses on financing scalable earlier stage projects with a significant social impact. Prior to her position, she was in Germany for 3 years for the Finance in Motion GmbH, and was a recipient of the Robert Bosch Foundation's fellowship with a focus on development finance. We are also joined by Jane Newman, who is the International Director at Social Finance, where she leads the work to develop and support the international network of social finance collaboration partners, and works with intermediaries, foundations, and others in many countries to support the development of impact investing and outcomes-based social finance approaches. She was previously the Director of Governance and Company Secretary at the Social Investment Business, which is a leading UK social investor. We are also joined by Dr. Yao Opoku-Boateng, who is a medical doctor, a public health practitioner, and has a degree in health economics, policy, and management from London School of Economics. He has been working with the National Health Insurance Authority in Ghana since 2017 and has held several portfolios. He is currently the head of data analytics at the National Health Insurance Authority and the lead person in the pilot phase of the value-based care implementation at the National Health Insurance Scheme. And then last but not least, C.T. Wouters is Program Director of Innovative Finance for the UBS Optimus Foundation, where he works closely on the design, structuring, and contracting of the Quality Education India Development Impact Bond and the Utrecht Maternal and Newborn Health Impact Bond, Development Impact Bond. And prior to his current role, he worked within UBS and Society, an umbrella platform within UBS Group, to grow the bank into a leader in the sustainable banking sector, as well as within strategy development at UBS Asset Management. So with that, I will turn it over to John Fairhurst to moderate this conversation.
Thank you very much, Emily, and also Nicole for that fantastic introduction. It's always slightly daunting to be moderating a panel where it takes sort of 10 minutes to introduce people's bios, but I hope it gives you a sense of the expertise that we have in front of us. So really want to move to talking to the panelists and get their inputs, but please do ask questions. This is very much for people to get what they need out of the conversation as well. I mean, I think Emily and Nicole set this up incredibly well. What we see is a huge amount of promise and possibility for outcome-based financing for these kind of mechanisms. But I think we recognise that we haven't yet fulfilled that promise, and there's many of the learnings that came out of Zurich that will help us build and scale this. I think we know this isn't the solution to every problem too. And one of the key things I think is about understanding, where this is the right model, where this solves a problem with the right structure, the right financing structure as well. So in order to leverage the efficiencies that Nicole spoke about, how do we understand the experience of these instruments and what we've learned in order to make sure that we use them in the most effective way with all the stakeholders that we have at the table. So with that, Jane, I'd like to maybe come to you first, if that's okay. Social finance was really at the founding of this concept, and you've supported a number of these instruments, both in the UK in high income settings, but also in low middle income countries. I'd be really interested to hear your perspective on, what is the value proposition? What's the evidence of the benefits of this kind of model of contracting from your experience?
Thank you, John, and hello, everybody. Thanks also to Emily and the Brookings team and other members of the panel. It's really good to speak to you today. So just to set that up, social finance works extensively on outcomes-based finance in the UK, but also internationally. And I'm going to focus my comments on a project that we've done in low middle-income countries and use that as a sort of use case, effectively for comments. But I think in terms of looking at how they can work in a mature health system, we are really starting to feel that we have a means of engaging with our National Health Service around particular models to understand exactly how to insert an outcomes-based approach into their programming in a way that resonates with the sort of constraints that they work with. But that's not for today. I'm going to talk a little bit about a program that we helped support also in Cameroon, actually, which was focused on reducing infant mortality and preterm low birth weight babies as an example of how some of the learnings that we see and the benefits of this kind of commissioning. This program was called, for convenience, Kangaroo Mother Care. The intervention model was based on skin-to-skin contact and breastfeeding for new mothers. And it was evidence-based from another setting, Colombia, but hadn't been used in an African setting, but had been identified by the WHO as a highly promising model that had the potential and should be implemented in other settings. So the advantage, perhaps 3 points really I want to make or to highlight for the benefits or the use of outcomes-based models in this context. One is the flexibility. People talk a lot about flexibility for impact bonds, but I'll talk about how that benefited us in this case. Secondly, the partnership amongst the stakeholders, which is a really important way in which people come together and drive their shared focus towards outcomes. And thirdly, the really important role of government, as Nicole was saying, if you're really going to try and embed this for the long term. So very briefly, on the flexibility, I think being able to come together around a clear focus on specific outcomes in a context where you understand in the KMC case what the essence of the model was, but you have no idea really how to operationalize it in a different context. Having a model which enables you to focus on the outcomes and as you implement it, learn, adapt and change with rapid learning cycles. So in that particular case, we were setting up measurement points every quarter, but that gave us rapid feedback and a quick opportunity to understand, try and understand what was working, what wasn't working, and how to adapt. The second point there was the partnership with the stakeholders. We had a governance structure that brought the government, the outcome payer, the investor, the implementer around the table with quarterly review meetings looking at progress. And that meant that from the beginning, everyone was focused on the endpoint and were working together on challenges and adaptations as they came along. So it enabled us, as I say, to operationalize, but also adapt. And we were better at sort of troubleshooting when there were sort of issues always emerge on any program. But we had a shared objective in finding solutions, and that really sort of showed its strength really when COVID hit, because obviously the biggest pivot in the program was to responding to COVID. But the fact that the governance group were already working together in that way meant that it wasn't straightforward, but it was surprisingly possible to implement something as close as possible to business as usual, and we managed to continue the program throughout COVID. And the last point was just on the government, and absolutely right that the government should be, if possible, be brought in at the beginning. Our goal with this was to think about this program in terms of how it could be embedded in the Cameroon system for the future as a sort of health system strengthening kind of approach. So government had to be part of it, and they were an outcome funder, but they had back funding from the Global Finance Facility. So we had quite a complicated contracting structure, just to Nicole's point. But that did mean that I think it's very challenging with a program which is sort of piloted outside government and then you hand it over and say, here, this works. But by involving the government from the beginning, what we were seeking to do was to have them own the benefits and the learnings of the system and start the process of transition into the government system as early as possible. So for the last year of the delivery period, although we were continuing to implement the bond, we were really focusing on how it might sustain beyond the end of the bond, and getting budget lines into the next year's budgeting. I've got lots to say, but I will stop there because I know others have lots to say as well.
Yeah, sorry, Jen. No, it's really fascinating, and it leads a little bit into my next question, because I think, you know, one of the criticisms of these instruments is that they take a long time to build, and the comment about lawyers being the biggest beneficiary tend to hang around. But I think there are many kind of intangible pieces that are built through the construction of the kind of stakeholder partnership that you talked about that are not always built in the same way by other mechanisms. So I'd be interested, Fareed, I know, and we've obviously worked together closely on this, that you've had experience of the time it takes to build these instruments. I wonder if you could just tell us a bit about that experience of building it. And is there anything you learned in that design process that you think people on the call should know from that?
Well, good morning, good afternoon, everybody, and thanks, John and Emily, for asking me to say a few words. It's always a little embarrassing to be marked up as someone who took long to put a transaction together. But the honest truth is that these transactions do take a long time to put together. In our case, it was as long as 4 years. So quickly, just to remind you what that transaction is, it's an impact bond, a social impact bond to address the needs of young women for HIV and reproductive health. And, we set 4 targets linked to antiretroviral treatment, pre-exposure prophylaxis, contraception and early antenatal care, ambitious targets. And the transaction was put together by the Medical Research Council, which is where I work. And it's a kind of a government institution with a little more leeway than an independence than a government department. So that's the setting. I think a couple of a few important lessons to learn. One is that being a research organization, we over-invested in researching the problem. We spent quite a lot of money and a lot of time scoping all the data, but also commissioning our own research. And I think one must be careful about entering into transactions where there are data gaps and areas where you're not really aware of what the latest evidence is. In our second transaction, which we're putting together now, we learned lessons from that by just doing a simple literature review and a harmonization of data. And in a few months, we have a good understanding of what the second SIB, which is on multi-drug resistant TB, should be. So that's the first thing, is that you can spend a lot of time researching the subject, researching your baselines and counterfactuals, and figuring out the digital health, the reporting systems. So start with programs where there's sufficient information and knowledge about how to do these things. The second thing I'd point out is that we took a long time to firm up the outcomes funding, even though we had it on budget, and the MRC moved kind of from an intermediary role, putting the transaction together, into an outcomes funding role. But there's a lot of complexity in government systems to allocate funds. And, we made the mistake of not forcing our Treasury to issue a guarantee. So there was a lot of instability on the government side for this funding. We now have firmed that up, but if you don't have the outcomes funds firmed up, and the place and the role and the commitment of government, you're opening up a whole new category of risk. So I think one must be aware of that. It takes a long time to put these things together, but also they have to be done. I think the third risk is that each of our regulatory environments is complex. And in our case in South Africa, we don't really have a pathway to get approval, regulatory approval for this transaction. And for a government agency, this looks like a loan. And you can imagine the rules that have to be followed, the approvals you need to get if you want to borrow money from the markets. And it became even more complicated when you wanted to borrow money for which you already had a budget. People couldn't really understand why you needed to borrow money. And of course, the returns and the reimbursement of the capital is variable because it depends on the achievement of outcomes. And unless your regulatory environment, your Treasury, or all your committees giving you approvals understand what it's about. So we took a long time. It took as long as 8 months just for the Treasury to process this transaction. And John, I'll end by saying that herein lies a bit of complexity. Do you bring the implementer and investor on board before you have the outcomes funding, or do you have the outcomes funding first? I think we went around in circles really a little bit there. And now we know that there are two pathways here. One is if you have the outcomes funding, you secure it, that you're running the transaction, then start with determining what you want and commission the project. If you're an implementer and you partner with an investor, that's a very different route to putting this transaction together. So figure those things out before you go. I'll stop there just to say that I hope we have learned lessons that our next transaction will take between 12 and 18 months. There's complexity here, so it's going to take a long time, and it's better to plan. Don't think you can put this transaction together in 6 months, at least not in a country like ours. Thanks.
Yeah, no, that's really helpful. And it sounds like a simple lesson to say to understand your context. But I think it's really key that the regulatory piece can take a long time, particularly if it's sequential. But I think to go back, to what Jane said, I think building this around evidence. Understanding the data that drives the solution that you're implementing, or the outcomes that you're driving, is really key. And you very conveniently mentioned the investor and whether you start with the investor. So if it's okay, I'm going to move to Dia from the US. And Dia, you were an investor in an impact bond in Cameroon that and some worked on cataract surgeries, and I think delivered something like 18,000 surgeries over 5 years. So you can tell us whether that was a success from your perspective. But I'm just interested, listening to Farid's perspective, why you made that investment, what made it attractive, and what's your perspective on that? The idea about needing outcome funding or first before investors as well. But thanks very much.
Sure. I think there's a lot of nuggets in this conversation, and just want to build on that. And actually, the Cameroon cataract bond is still in progress. To date, we have made over 13,000 surgeries and met all of our social impact targets for the first check-in point. The second and final check-in point will occur in 2025. And hopefully at that time, we will get to the 18,000 surgeries. But very excited about this project. And I can tell you, for us, this was DFC's, at the time, OPIC's first development impact bond. And so for us, it was a matter of having a real conviction around investing in this transaction. And that stood out because of the deep developmental impact, the idea that we would be providing high quality cataract surgeries in a business model that supported all aspects of the population. And one of the key social impact targets for this bond is to work with low income and rural populations. So the idea is to have a cross subsidy business model that provides for upper middle income individuals to be able to pay a fee for service that allows the hospital to subsidize the cost for lower income populations. And that's actually part of our social impact metric. So that deep developmental aspect of it was really important to us. I think to Fareed's point on the outcome funders versus the investors, we came in after the outcome funders and the service implementer had coordinated and had their discussions, and we were really excited about the commitment of the outcome funders and also their flexibility. There was a little bit of changes or adaptation to work with us, but that really stood out. And the implementer was very knowledgeable and had a much larger vision than we just want to implement this project. I think their vision for building out the space, integrating with the community really stood out to us. Also, as I mentioned, it was an innovative business model, but investing in a DIB was an innovative product offering. And at the time, we could see that this would be a way for us to invest in development in ways that we couldn't invest with a commercial loan or equity, or even maybe a more concessionary loan, right? I think with DIBs and with results-based financing, you can create investment opportunities that would not necessarily be there with a more straightforward product. So this for us was, as Nicole mentioned, a demonstration effect. So we wanted to make this investment as a demonstration effect for DIBs in the market, but also for us as DFC. And we've gone on to make other investments, but this fit well as far as timing and size to make the investment through our Portfolio for Impact and Innovation program. And then I'd say another key aspect was the social impact metrics. Not only did we deal with number of surgeries, as you mentioned, John, quality of surgeries, but one of our metrics is that the hospital is sustainable. And that's really important, as Jane mentioned, to see that sustainability long-term after the life of the bond. So we wanted to see that they would still be able to impact the community and the country. I think if I go really quickly to lessons learned, one of the things I think is really key, whoever you bring in first, whether it's the investor or the outcome funder, or it's an implementer that has an idea of a new way to do business, is bringing all the partners together as early as possible. That's something that after this first transaction, I've always mentioned as we've discussed other transactions. And I think it's very beneficial in terms of timing, but also flexibility and ensuring that everyone's able to achieve their goals and work within the constraints of their operating system. I also think it's really important to have an intermediary that is a driver of moving through the process and has a clear understanding of what all the parties want to achieve. That's been essential for us and the investments that we've worked in. And then I just end by saying DFC is really excited about these types of opportunities in the future. We've actually created a new department, our Office of Catalytic Investments, where we want to catalyze and build markets. And I think that results-based financing or outcomes-based financing is a real critical area as we look at healthcare as a sector, as well as climate and others, employment, education as well. So I'll pause there.
Fantastic. Yeah, no, I think really exciting, and exciting that you did a proof of concept and it's built the enthusiasm forward. If we get time, there's a lot of questions about kind of financing sustainability. So just to warn you, I might come back to you at the end with some questions on that. But just if we can move on, because I know time's running out. But yeah, everybody's mentioned the importance of government in these and the centrality of engaging government, but also the challenges, around regulation and systems. I know you haven't been involved in outcome-based financing exactly, but you are running a very interesting program on value-based health services. which has many similarities, I think, with the goals of outcome-based financing. So I'd be really interested to understand, what is value-based care, and what was the motivation to pilot that in Ghana as well.
All right, thank you, John, and thanks everyone for giving me the opportunity to talk about our story on value-based care in Ghana. Basically, I would say that value-based care is new to us as a country, and probably to the continent of Africa in general. Largely, I think a few countries, maybe South Africa, is probably practicing value-based care. So value-based care came into the program or the structure of Ghana healthcare system when National Health Insurance Authority, which is the main financier of health in Ghana, saw an increasing rise, or increase in the number of non-communicable diseases, especially hypertension. And data also showed us that less than 15% of hypertensive patients that are going to the facilities, healthcare facilities, are getting their hypertension levels controlled, which means all the reimbursements that the National Health Insurance Authority is doing does not complement with the outcomes that we are getting in terms of the healthcare of the patients. Therefore, we need to re-strategize because the investments there, we need to see results. That is where the value-based care option came in, where we're using hypertension as a pilot to study the efficiency of the healthcare practice that we're doing in Ghana. So with the hypertension cases, we kind of studying a number of patients within some healthcare facilities. We are in a pilot phase now, and we started in August, where we are monitoring the BP values of these patients for a considerable time to be able to see how the patterns are going. And then based on that, we would be able to make a meaningful outcome out of it. Maybe I would go in a bit into what we've seen so far, and that is where we see the value that we are seeing in the program that we are doing. Yes, for some time now, we've realized that the number of patients that we are doing as a pilot, though the national statistics shows that we are having about 15% of the patients attending healthcare facilities getting their BP controlled, the patients that are within the value-based care pilot, we are having close to 50% of them having their BP values controlled, which means there is a significant increase in the value-based care that we're practicing. And that is an urge for the authority and probably government at large to be able to implement the value-based care. But like I said, we are still in the pilot phase. We are now kind of doing the outcomes measurements, and it's based on that would be able to make projections into the future. However, this has not come easy. There are a lot of challenges that came with it. Some of the challenges included with the healthcare facility, they had challenges in terms of the time that they need to spend with the patients, because the value-based care puts the patient at the center of the care. And therefore, education of the patient needs to come in. The patient needs to be aware of the condition that he or she is being treated for. And that would definitely encourage the cooperation of the patient in terms of the management of the disease. Therefore, the time spent at the facility level or the healthcare provider level is quite a lot, and that is a challenge that we're having. Another aspect is the human resource. Also a challenge because we need the number of health personnel to be able to do health education and all other aspects of the healthcare chain. And that puts, because we have limited human resource, it makes the work a bit more difficult in achieving the volumes that we need to achieve within a certain period. However, efforts are being made to do that. One component on the part of the healthcare provider is cost. And I think cost cuts across all the various in terms of the healthcare provider, the patient himself, and then the insurer or the payer as well, because they need to increase their human resource to be able to compensate or commiserate with the volume of patients that are available. They need to hire more healthcare personnel, and that increases their costs. More resources come in, and therefore puts a toll on their budgets. So that is one area that a challenge that healthcare providers are facing greatly in terms of value-based care.
Sorry to cut you off because it's really fascinating, but I'm just conscious of time. But I mean, I think one of the interesting things that you're saying is how, in essence, the focus on outcome actually drives the different thinking about how you get to the outcomes in terms of increasing human resources. It kind of reveals that maybe the old way of working isn't as effective, and therefore you need to work differently, which I do think is one of the powerful elements of outcome-based funding, is that it puts the emphasis, to your point, on things like patient-centric care. And patient-centric care means doing things differently, maybe to service-based care. So really fascinating example. Would love to hear more, but I'm afraid I need to just move on to Tsitsi, otherwise we might not give him a chance to speak. But thank you very much for that. So, Tsitsi, just you've in UBS Optimus has been also at the beginning of many of a number of different outcome-based funding instruments. The Utrecht bond, obviously a significant one. Working on maternal newborn health in Rajasthan. I'd be interested if you could just share some of the lessons you learned from building that one particularly, but also from the other ones that Optimus has worked on.
Super. Thanks, John. And I think a lot of the lessons are actually similar to the lessons that Jane spoke of, and key lessons there are really kind of around the flexibility and around continuous improvement of the model, and echoing as well what Jane was mentioning around COVID. During the COVID pandemic, we really saw how the model was really able to work in these times of uncertainty and actually overachieved on results within the time period, and both within Utrecht, but also, for example, in the education dip that we did at the same time in India, and how that flexibility really, despite, for example, with the education schools being closed, we actually were able to still educate children. The same for the Utrecht bond. We were still able to move these clinics to higher quality levels, and I think that's really been a fantastic result, and really shows the strength of the model, which I think is then great for the next step, as in how we can think about scaling, because I think we've had such great results. We've really been able to prove out how this structure works fantastically. I think the challenge on us as a space is really now, how can we scale this going forward, and how can we think about embedding new ways of working to work also in the longer term, because a lot of what we've done has actually been only 2, 3, 4, 5-year programs, and what we're trying to do is to make sure we change, enable systemic change that lasts for 10 years, 20 years, and continues to get those improvements, and work with sustainable funding streams, work with governments to see how we can redirect maybe some of these sustainable funding streams to keep focusing on outcomes, rather than redoing these 3 to 5 year programs where you will have the same kind of setup problems. So rather set it up once and then see how we can run it 10 years within, let's say, a government context or with sustainable donor funding streams.
Yeah, fantastic. Well, I think it's been a great example of one of the larger bonds over time, and I know Optimus stays remarkably optimistic about the potential of these. But we'd just like to move to a few questions, if that's possible. We've had so many questions, I'm not quite sure where to start. But there's definitely a number around the sustainability, and I think that the challenge here that you create an investment vehicle that is creating change. And I think we've seen, from Dia, from Sitin, and I think also from Yao and Farid, how these kind of mechanisms create kind of impact change. But I guess the question, like any of these kind of financing mechanisms, is after that financing period is over, after the 5 years has finished in Cameroon or also Rajasthan, how are they sustained? And is it necessary for further financing to continue? But be interested, maybe, Dia, just to start with you, because you referenced it, and then perhaps also to come back to you, Tsitsi, just to talk about how do you see that sort of longer term success of these instruments?
So just I'll do a short response. I think in the first one, in the Cameroon project that we discussed, it is implied within our social impact metrics that the Africa Eye Foundation is sustainable. So one of the metrics is around operations and then being EBITDA positive by the time we exit our investment. And the idea is the hospital will be self-sustainable and able to continue operations in the future. I think in other transactions, and I'm thinking of another transaction that we worked on that was a development impact bond. A lot of it was about the thesis of the organization we were supporting, which was a nonprofit, and their view to move towards more sustainable impact-linked financing versus reliance on donor funding. So I think the sustainability question is very difficult, but it can be addressed in different ways depending upon the project. And something I saw too, just one other note, sometimes the sustainability could not necessarily be operating on their own for cash flows, but being able to move, if you're a nonprofit, to a model where you can have longer term kind of donor funding or financing to really implement change versus short term 1 year funding where you can't really do a lot of the strategic planning.
Right, thank you. And Tsitsi, do you have any thoughts on the sort of long-term sustainability?
Yeah, absolutely. I think we need to kind of take a step back and think a little bit about, what really are the needs that governments have. Have this dialogue with governments, insurers. What are their needs? What are their priorities? What do they want to fund? Because these are also the areas that they'll have money available for longer term pay for result structure, and then see how there you can work on pay for result structures and really focusing on the price per outcome and working with beneficiaries on structures that can really be in place for the long run, where they really create continuous improvement for the beneficiaries. And of course, at the end of that, of course, if there are investors needed, that would be interesting for us, would be great. But I think if we keep focus on that, as we've done in all the pilots, we'll be very technical about it. We focus a lot on how great our structures are and all the investors, blah, blah, blah. But I think we need to take a step back and look at what is the value we're creating here for patients, what is the value we're creating for governments, how can we sustain that in the long run, and how would we then solve that with the structure behind, but focus less on the structure. We know now how that can work. That's kind of a boring story now. Now we need to focus back on the results for the beneficiaries and improving those and implementing this kind of way of working.
Yeah, fantastic. I mean, I think what you both said, I think is really, you need to design the sustainability in. If you only see this as an intervention, then clearly, like any intervention, like any funding, it's hard to build sustainability. Just another question as well that's come up, and we've mentioned the kind of centrality of government, and there's a question which is, which maybe to you, Farid, and also Yao, is how do you convince governments to take these on? Whether it's value-based care or the impact model that you led. What's the case that you make that convinces governments to make the kind of investment in these new kind of mechanisms? How would you articulate that, Farid, maybe first, and then Yao?
Yeah, thanks, John. That's a great question, and I think one has to fall back on the sort of bottom-up pressure, fiscal pressures that treasuries are facing, and there's more and more interest now in using government money better. Certainly in our context, and I think across the continent, and the kind of economic effects of the pandemic have really highlighted this. And what's happened is that the people in the treasury who are interested in making sure that every rand is stretched to as far as it can get through these sorts of contracts are showing interest. But what's interesting is midway through our transaction, we broke the records on the provision of contraception, and overachieved by 250% of the target, and that has led to widespread interest from the education department, the schools department, the health department, because they've never seen a result like this, So I think there's these are the sorts of things that get governments interested. The hard part is to get the first transaction through and the pilots in, which is what we're all doing, right? But if we can show results, that certainly attracts the attention of the decision makers. I mean, it links back to the sustainability issue also, which is we've had our education department come forward saying, we're not interested in the other three outcomes, but this pregnancy in schools is a big problem for us. Can we talk about scaling that aspect up? Thanks.
Fantastic. Yeah. So I guess it's results ultimately. But yeah, you've obviously implemented or starting to implement this value-based care. How did you make the case?
Yeah, thank you, John. Like I already said, you realize that our costs was on the rise in terms of non-communicable diseases, which is led by more or less hypertension. And because of scarce resources, we needed to put in measures so that we would be able to make effective utilization of the resource that we have available. And that is one of the mechanisms that we can put in place to ensure that the scarce resources that we have are being put to effective use. The data was presented to the healthcare providers that you attend to these patients, but this is what the data shows. You are achieving only less than 15% of the results that need to be achieved. Therefore, which shows that we are reimbursing you at a rate at which you do not deserve. And therefore, if we do not achieve the results, then we may need to put in measures to be able to maybe lower your level of care, which attracts a higher tariff, or give you a slower tariff so that you would be able to compensate for it. So based on that, they understood the concept that we're trying to implement and therefore bought into it. And we hope that as we're getting more results to show them, they would be edged on. But one challenge that probably I couldn't talk about was the financial bit, the reimbursement package of value-based care. Like I said, Ghana is in the frontal now. Therefore, we've not gone far ahead to be able to see how the reimbursement is going to be done. But we are working in that process with support from pharmacists. We are working on it, and we hope to get there to get the right tariff to commiserate with the care that is being provided. Thank you.
Fantastic. Well, I really look forward to hearing more about the pilot. And then I hope Emily will give me one more minute just to wrap up. But Jane, I've not asked you to summarize the panel. But I don't know if you have any kind of final thoughts on either the sustainability or the government engagement problem. And then really thank you to everybody for a fantastic panel. Fantastic information, and I think, as Dia said, some real nuggets in the conversation. So hopefully it was useful. But Jane, just for the last word, let me hand over to you.
Thank you. I mean, I think this has been an incredibly interesting panel, and thank you, John. I think my last word is that I always think of an impact bond as being a sort of a really powerful instrument of change. But what we're trying to do also is to change systems. They might be large systems or small systems, and I think that it's really important when you sort of enter into your transaction to think about what's next. So you sort of think about what the routes to sustainability or what comes next, or what is the next step or route in your sort of system change model that comes. So I think that's probably one of the most important reflections we've had at Social Finance, that we realize that we are using instruments for a purpose, and we need to think about the broader system in which that we're implementing those models.
Wonderful. Thank you, John, for moderating this excellent panel. And to all of you for joining from various corners of the world. I know some of you are at high-level conferences that you have stepped out of to be able to join us today with your expertise. Clearly, in an hour and change, it's hard to get to all of the issues, but I feel like we've covered some of the main topics today. Jane, I think you summarized precisely what I was going to say, which is that at the end of the day, this is really about, not some fancy financial instrument, but it's really a pathway to systems change for longer term sustainability, which really puts patients at the center. And with that, so as a follow-up to our Zurich workshop, we felt that that was kind of a kickoff to a community of practice around outcomes-based financing. Clearly, there's more sharing that needs to be done, more learning to really take this agenda forward. So I'm going to share now a QR code. We're really curious to know if those of you who have joined us today would be interested in joining a community of practice on outcomes-based financing for health. So you can take a shot of this QR code. If you are interested in joining. You're also welcome to email us at obf@brookings.edu. If you're interested in joining, or if you have any thoughts about today's conversation or about the future of outcomes-based financing in global health, please do fill out the survey. And with that, again, I would like to thank all of the panelists for your excellent comments and to Nicole for your introduction. Really look forward to taking this conversation forward. So much work to be done given the challenges that we face today in the globe. So thank you.